Hi, I'm Tim Tanzer, and I'm a clinical pharmacist from the Princess Alexandra Hospital in Brisbane. Today, I'm going to discuss how to assess drug-induced QT changes for pharmacists. This is a topic that historically has caused a lot of confusion for pharmacists because if you asked a toxicologist, a cardiologist, or a drug manufacturer how to measure the QT interval, you might get a different answer from each and for different reasons. As pharmacists, it's our job to be the experts on judicious management of medications and adverse events. So I hope that after today, you'll feel more confident in your decision making, and you'll know which things you really need to worry about when it comes to QT prolongation. Measuring the QT interval in clinical practice is important because of the risk of a condition known as torsades de poids. Torsades de poids is a type of polymorphic ventricular tachycardia, and it's French for twisting of the points. Its name represents the image that you see here. This is what an ECG looks like when someone is experiencing torsades de poids. And what you are seeing are multiple QRS complexes, morphic, so polymorphic. So what we're looking at here are multiple high amplitude and low amplitude QRS waves. In other words, these are heartbeats. And due to these rapid heartbeats, people with torsades de poids might deteriorate into ventricular fibrillation, and the patient may not have time to fill the heart with blood between beats, and thus have difficulty circulating blood to the body. This is what leads to the syncope, cardiac arrest, and sudden death that is associated with torsades de poids. Torsades de poids is always preceded by a long QT interval. So what is the QT interval? An ECG, or an electrocardiogram, is a device that records the electrical signal from the heart. Certain characteristics of an ECG wave are represented by letters. The P wave represents atrial depolarization. The QRS complex represents ventricular depolarization. And the T wave represents ventricular repolarization. Let's remember that torsades de poids is a type of polymorphic ventricular tachycardia. The key word here is ventricular, so we can forget about the P wave for the purposes of this talk and focus on the interval from Q to T. The QT interval begins at the beginning of the QRS complex and ends at the end of the T wave. And it represents the length of time where the ventricles depolarize and repolarize. In other words, this represents an action potential, an electrical impulse designed to trigger a heartbeat. And just like any action potential, this electrical impulse relies on the flow of ions in and out of cardiac muscle cells through ion channels. The depolarization phase, that is, the QRS complex, is a result of sodium influx. Then there is a period of time where potassium efflux and calcium influx balance each other out. And then the repolarization phase occurs where the potassium efflux dominates the calcium influx. This period, the T wave, represents repolarization. So that is the end of the recovery or refractory period where potassium is flowing out of the cells. This allows our action potential to charge up and be ready to fire another heartbeat. So in the context of clinical practice, what does this mean? It means that people with a normal QT have good function of ion channels, and people with a long QT have a delay in the repolarization or recovery time of this action potential. And when there is a delay, a prolonged QT interval, it is typically due to an abnormality or a disruption in the function of these ion channels in cardiac muscles. So specifically, an abnormality which either increases the function of sodium and calcium channels or decreases the function of potassium channels will prolong the QT interval. So why is this important? The longer that it takes to recharge these action potentials of cardiac cells, the greater opportunity there is for what is known as a re-entrant pathway. Because of the delay in recovery time between heartbeats, this may cause the electrical impulse to travel around in loops and trigger extra heartbeats in the ventricles before the previous heartbeat was able to recharge or repolarize. These extra premature heartbeats will be represented as QRS complexes. So this circular electrical impulse in the cardiac cells of the ventricles is what causes the characteristic wave pattern of Torsades de Pointes. So what causes a prolonged QT interval? Congenital long QT syndrome is the most common cause, meaning there is an inherited genetic mutation that causes abnormal ion channel activity, and this may mean you are either born with the disorder or are at risk of developing it later in life when exposed to risk factors. Long QT syndrome can also be acquired from things such as cardiac injury. Electrolyte disturbances can have a direct impact on the function of ion channels, and medications may also disrupt the function of these ion channels, most commonly the potassium ion channel. And as you may know, there are many drugs which come with a warning of QT prolongation, and misuse or overdose of these medications may increase the risk. People with long QT syndrome typically will be asymptomatic and may not be aware of the condition, so long QT syndrome may not be detected until the patient is in ventricular tachycardia or cardiac arrest. As a result, long QT syndrome can cause sudden death in otherwise seemingly healthy people. And this is quite terrifying. It's why strict monitoring for patients who are prescribed QT prolonging agents is recommended. So what is a normal QT interval? For adult men, the average is less than 430 milliseconds, and for women, it is less than 450 milliseconds. A prolonged QT is generally accepted as greater than 440 or 450 milliseconds for men, and greater than 470 milliseconds for women. When you are measuring the QT, each small box is 40 milliseconds in length, and each large box is 200 milliseconds in length. You can measure this manually by counting the squares, using a caliper tool, or you may be able to use a digital measurement tool in digital hospital charting software. Don't worry if you can't measure the QT interval to the exact millisecond. The methods used to measure the QT are not very sensitive, and if you can estimate it within 5 to 10 milliseconds, you'll likely be more accurate than an ECG machine. When we're measuring the QT interval, as we discussed earlier, we are measuring from the start of the QRS complex, and we are ending at the end of the T wave. So you can measure this distance with your caliper tool or by counting the squares. In the example on our screen, the length of the QT interval would be 320 milliseconds. In order to achieve the most accurate measurement of the QT, we need to measure 6 different leads, 3 from the chest and 3 leads from the limbs. If you have trouble remembering, remember that V stands for very close to the heart. That might help. What you do is take the median value of these 6 leads. That's the middle number, and that will be your measurement of the QT interval. Let's use an example here. This is an ECG report for a patient. We've measured 3 limb leads on the left-hand side and 3 chest leads on the right-hand side. You don't need to use a calculator. Let's get rid of the highest 2 values, which is 458 and 451. Then let's get rid of the lowest 2 values, which are 418 and 431. We can then take the average of the middle 2 numbers. So the QT interval using our manually measured method would be 438 milliseconds. So at this stage, we know that a prolonged QT interval leads to a chance of reentrant pathways, and this is why we measure the QT interval. It's very important. But unfortunately, it's not just this simple. There are a few caveats we need to factor when trying to assess if someone is at risk of Torsades de Pointes. Firstly, it's important to understand that the QT interval is rate dependent. What this means is that because the ECG machines record at a constant rate, the physical distance between heartbeats directly affects the length of the QT interval. You can imagine the machine like a printer printing out paper at a constant rate. If the heart is beating faster, the time, and thus the length between the beats, will be shorter because there are more beats that make it onto the page. And of course, if the heart is beating slower, the QT interval will be larger simply because there is more time between beats and thus a greater distance between beats. So as we know, individuals have varying heart rates, and so this rate dependence of the QT interval makes it difficult to identify which patients have long QT syndrome and are actually at risk of ventricular tachycardia and torsades de pointes. For this reason, we have to correct the QT interval for heart rate in order to account for this rate dependence, and this is known as the corrected QT interval, or the QTC. And there are various formulas available to calculate the QTC. As an example, here are two patients with differing heart rates. One has a heart rate of 83 beats per minute and a QT of 371 milliseconds. The other has a heart rate of 104 beats per minute and has a QT of 291 milliseconds. Both of these patients have the same corrected QT interval of 440 milliseconds. So although the length of their QT is different, their risk of cardiac events is equivalent. The second important factor to consider is the reliability of the QT value on the ECG reports. The ECG machines automatically measure the QT interval and conveniently give us this value displayed either on a paper or digital report. Unfortunately, we can't rely on this value. The machines typically overestimate the QT interval and on occasion can have some difficulties identifying the end of the T wave. When we compare the machine's automatically measured QT interval values with our validated manual measurement methods that we learned earlier, the difference works out to be about 20 milliseconds. That means, on average, the machines overestimate the length of the QT interval by around 20 milliseconds. The next factor that we must consider is which formula we choose to use to calculate the corrected QT value. The Bazard's formula is the most widespread and commonly used formula, and is often the default formula used on the ECG machines. This formula was derived based on observations from a study in 1920, which only had around 35 patients. Since that time, other formulas have been developed, including the Fredericia, Framingham, and Hodges formula. The Framingham formula has the most weight behind it. It is based on the Framingham Heart Study, which had over 5,000 subjects. So which formula is the most accurate to assess the risk of torsades de pointes? Studies suggest that the Bazard's formula, which is the most widely used formula, overcorrects at high heart rates. Let's look here at a study which graphically mapped the Bazard's formula at 440 milliseconds. You can see that the little triangles are cases in this study and the circles are the controls. As you can see, the Bazard's formula falsely identifies many cases of prolonged QT syndrome who are not at risk of torsades de pointes. You may hear that 500 milliseconds is a more concerning benchmark for those with long QT. And when the authors of this study used 500 milliseconds, that is the dotted line, it lines up a bit closer to what the data is telling us. However, at 500 milliseconds, the Bazard's formula runs into a new problem. You can see that in bradycardic heart rates, the Bazard's formula undercorrects, and there are actually cases of torsades which would not be identified in heart rates of less than 60 beats per minute. Some of the other formulas available, in particular the Framingham and the Hodges formula, do a much better job of reducing the number of false positive cases of prolonged QT. However, none of the formulas appear to be perfect in both reducing the number of false positives and identifying patients in bradycardic heart rate zones who are at risk of torsades. Due to this, a QT nomogram has been developed using raw QT and heart rate pairs. So rather than using a formula to correct the QT, you can plot the QT and heart rate pair, and if it lands above the line, the patient may be at risk of torsades de pointes. And if it lands below the line, they may not be at risk. As you can see that when you match the nomogram with this dataset we used earlier, it much more accurately identifies patients who are at risk of torsades and doesn't miss patients in bradycardic heart rate zones. The dotted line section exists to extrapolate the risk at high heart rates. This is because A, it's hard to read the QT interval at high heart rates precisely because the physical distance between beats becomes smaller. And B, tachycardia is actually protective of torsades. Patients are much less likely to develop torsades in tachycardia, and in fact, some of the treatment of torsades can involve increasing the heart rate. This is because it reduces the time between beats and thus reduces the opportunity to develop those premature QRS complexes, or those re-entrant pathways, in the refractory period of our heartbeat. Allow me now to demonstrate why relying on the ECG report values, where the machine automatically measures the QT and uses the Bazit's formula, is not a reliable way to identify patients who are at risk of torsades when compared to manually measuring the QT and using the QT nomogram. In a 2-year study of 920 patients at the Princess Alexandra Hospital in Brisbane, using the machine's automatically measured QT and correcting using the Bazit's formula, there were 217 patients who were identified as having a prolonged QT. When using our validated methods of manual measurement and plotting on the QT nomogram, only 6 patients were shown to be at risk. Of those 6 patients, 2 of them were actually not identified using the ECG report methods. So not only did the ECG machine and the Bazit's formula overcorrect 213 times, it failed to pick up 2 of the only 6 patients who were actually at risk of torsades. It is therefore likely that we greatly overestimate the risk of drug-induced QT prolongation in clinical practice. In fact, much of drug-induced QT prolongation is in fact likely due to drug-induced tachycardia. This is because we know that the Bazit's formula overcorrects at high heart rates. As you can imagine, many drugs were tested for QT prolongation using traditional methods during drug development. So many medications are flagged as potentially QT prolonging. This means it can be very difficult to work out which drugs actually prolong the QT in a meaningful way in the context of torsades de poids. Conventional advice given in most clinical guidelines is almost always to avoid or remove drugs which may be increasing the risk of QT prolongation. Unfortunately, due to the convenience of the ECG report values and the number of false positives that these values pick up, it is likely that in clinical practice, many patients are having safe and effective medicine therapy withdrawn due to the fear of QT prolongation, where the risk may not actually be present. This is why, in your practice, it's important that you follow the validated manual measurement methods and the QT nomogram in order to identify patients who are at risk of torsades de poids. Let's finish by discussing what to do if we come across a patient with suspected drug-induced QT prolongation. The first thing you should do is to measure the QT with your eyes, or use a caliper tool, and plot the QT and heart rate pair on the QT nomogram. If the QT nomogram suggests that the patient is at risk, before suggesting cessation of medication, first rule out electrolyte disturbances and a history of congenital long QT syndrome. Try and optimize their potassium, magnesium, and calcium, and make sure that the patient is not hypoxic or acidotic. The patient should have telemetry until the QT normalizes. If all of the above is accounted for and the patient is at risk, it may be appropriate to reduce or remove the medication that is suspected of causing long QT syndrome.